Let me invite you all to the 30th edition of the Kerala Society of Ophthalmic Surgeons PG Classroom. This is the 30th edition, and we have been discussing different cases, assessments, spotters, clinical trials, and a lot of things which would be beneficial for the postgraduates. Today, we are back with another case, and Dr. Aparna will be presenting a contracted socket. And we will be looking at evaluation of a contracted socket, which can come as a long case or as a short case. As you know, contracted socket is a very challenging situation in oculoplasty, which requires a multi-systemic management, and evaluation and assessment of that is also very important. So we have with us Dr. Marianne Polly, who is head of oculoplastics in Giridhar Eye Institute. She is a well-renowned oculoplasty surgeon who is presenting and publishing at will in a lot of places. And we have Dr. Shebin Salim, who is also an oculoplasty consultant at Giridhar Eye Institute. Over to you, Dr. Aparna, for the case presentation. You can share the presentation. And over to you, Dr. Marianne and Dr. Shebin. All right, let's start. We have approximately till 8:15 to discuss.
Yeah.
We can stop at about 8:15, 8:20. All right. Okay.
Good evening, all.
You can be slightly more louder, Aparna. Yeah.
Okay. Good evening, all. Presenting the case of 34-year-old gentleman who is a businessman. He has come to our OPD. He has come for fitting a new artificial right eye. His old artificial eye had broken while cleaning it 8 months back. History of presenting illness. According to the patient's mother, he gives history of right eye injury during birth due to forceps delivery. The patient had persistent discharge and pain in the right eye since then and was on topical eye drops for the same. Sometimes in childhood, he does not remember the exact age. The eye had burst, and since then, the eye size had decreased progressively over the years, and after that episode, the pain of the patient had subsided. The patient does not remember seeing anything with the right eye since childhood. At 18 years,
1 second. So, what do you think could be the possible etiologies? History is kind of vague, but we have to think of some etiologies in this case, right?
Ma'am, it could have been a corneal injury by the forceps, resulting in a corneal ulcer, and it could have gone in for a perforation, and it shows a thysical eye.
Okay, but they are not giving a history of perforation immediately after birth, right? They are giving history of bursting sometimes in the childhood. Or some other possible differentials?
It could have been an staphyloma, anterior staphyloma, or it could have been some other injury which has in turn leading on to thysical eye.
Okay, so we should keep in mind whatever possible deformed eye at birth. Could be an staphylomatous eye, or it could be a microphthalmic eye, or it could be a ophthalmic eye, something that the mother perceived as not a normal eye. We cannot entirely rely on this injury. Okay, yeah, continue.
At 18 years of age, he had gone to Kottayam Medical College, and he was given a ready-made type of artificial eye, and he was using it since then. He used to go regularly at 6 monthly for polishing the eye. He used to follow strict hygiene. He used to remove and clean it every day at night, and he did not wear it at night. The patient had been satisfied with the cosmesis and the movement of the artificial eye. 8 months back, while cleaning the eye, it fell from his hand and it broke. Since then, the patient has not been wearing it. He is also using a glasses which is full frame, but he is not aware of the make of the glasses. There's no history of use of any topical medications. There's no history of pain, discharge, or bleeding from the socket. There's no history of recurrent fall out of the processes from the socket. Moving on to the past ocular history, there's no history of any trauma, ophthalmic surgery, or implant placement. No history of any chemical injury. No history of any previous infection leading to the removal of the eye. No history of any childhood malignancy. No history of any radiation exposure. Past medical history, no history of diabetes, systemic hypertension, no history of bronchial asthma. Family history, there's no family history of any malignancies.
Okay, so let's go back to the history, past ocular history of presenting illness. Yeah. So what is the significance of each? What is the significance of polishing it? Asking the history of polishing, or when is the last time of prosthetic change?
Since he's polishing, since the patient is polishing it at regular intervals, there's no chance that the processes will be ill-fitting. So the processes cannot be ill-fitting because the patient is having regular follow-up. Then he is removing it at night, which signifies that there is around 10 hours of he removing the eye. So there's a chance for
and not the eye, the prosthesis. Okay.
Prosthesis. So there's a tendency for it affecting the socket.
How?
It can lead on to contraction because of the not wearing it for a time of maybe 7 hours. Yes, ma'am.
Yeah. And if the patient keeps on removing it every day, what other things can happen?
The patient keeps on removing it every day. There is a chance for the lower lid to become lax, and this will lead to lower lid laxity, and further manipulation will also stretch the lower lid, and this can cause ectropion and further falling out of the processes.
Okay. Anne is there? Anne?
Yes, ma'am.
So what is the importance of the make of glasses?
The glasses, they should be of polycarbonate material, usually tinted. They should offer protection to the socket.
To the socket? It should protect which eye?
The glasses should be.
The patient is one-eyed, right? Socket patient, his one eye is lost and now he is one-eyed. So the function of the glass, one is to protect the other eye. So that is why we are making the polycarbonate glass and also full frame. Okay, and tinted glasses can be used so that it will give a better cosmesis. Okay, yeah, and he is not using it for past 8 months, right? So that can lead to what?
That can lead on to contracted socket, and it can lead on to
yeah, that can lead to contracted socket. Okay, next slide. Okay, so what is the significance of each of this, asking each of this history?
No history of the topical medications to see, we are asking the history of topical medications to see when the patient is using any lubricants, because ideally it should coat, if there is a processes, it should coat all the surface of the lubricant should coat. It should be wet.
Not only the lubricant, yeah, they should be using one or the other lubricant, but also they may be using some topical antibiotics or topical steroid eye drops. That is also important. Okay, what can cause pain in an ophthalmic socket?
If there is
Brinda, what can cause pain in an anophthalmic socket?
If there is infection
Okay.
or any inflammation,
Any kind of inflammation,
then any like pyogenic granulomas,
yeah, can cause mild pain. Then any other causes?
if there is migration of that,
Implant migration, implant infection can cause pain. Migration can also sometimes cause pain.
and if there is any papillary conjunctivitis and all associated
That
with,
will not cause pain as such. Could it be some neuropathic pain?
any phantom,
It could be amputation neuroma. The nerve endings can hypertrophy and that can produce pain. Or can it be some? It can be some referred pain also.
okay, ma'am.
Some adjacent like sinusitis can also cause socket pain. So patient know that his eye is now abnormal. So whatever peripheral pain that can also get referred to the socket. It could be trigeminal neuralgia. Okay, what are the causes of discharge from the socket? Christy?
Any infection,
Okay.
any sinus formation into the deeper structures,
Which deeper structure?
intracranially,
Intracranial, no. Infection, then
through the
someone else can also answer.
any malignant lesions.
Don't go jump into big things. Okay, tell the common things first.
Because of the lack of lubrication.
Yeah, one is infection or any kind of inflammation, pyogenic granuloma or giant papillary conjunctivitis, or it could be, if the implant is there, it could be an exposure, implant exposure related infection that can cause discharge, or it could be an ill-fitting prosthesis that can also. How will an ill-fitting process will cause discharge? Vrinda? Whoever knows the answer can reply, okay?
ma'am, it will fall out of the eye, like patient often removes and takes out and again.
No, I'm asking how an ill-fitting prosthesis can produce discharge.
And it can irritate the mucosal lining.
See, as simple as that. There can be cracked edges, irregular posterior anterior surface. If the anterior surface is irregular, that can cause irritation on the palpebral conjunctiva, like inner side of the eyelid. Or if the posterior surface is irregular, that can cause the inflammation of the socket lining conjunctiva, or the phoneal conjunctiva. And if can a stalk shell use whether stalk shell use can cause discharge as compared to a custom-made prosthesis?
Custom made will be more preferable because it is made for the patient, taking the measurements. Where stock shell is ready-made type, so there's a chance for not proper fitting and
Okay.
ill-fitting and
Not proper fitting means there can be sometimes space between the posterior surface of the stalk shell and the anterior surface of the socket. So what will happen? The discharges will get collected in that space, and that will again cause irritation and a recurrent vicious cycle. Okay, but when we use the custom-made prosthesis, it will be molded into the anterior socket surface, so there will not be any space. Okay, so what are the causes for bleeding from the socket?
it can be because of any infection or inflammation, and because of
More specifically, which condition can cause bleeding? We already told.
because of any ill-fitting and
Yeah. Usually pyogenic granulomas can bleed, right? Okay. So what does it mean by frequent fallout of processes? What does it indicate?
it indicates that it indicates that the socket is not the correct size for the processes, and the lower lid has become lax, and
Okay. One thing, the lower lid could be lax. Then
and there can be formation of ectropion. Then there is a shelving of the lower fornix. The fornix is not adequate for
all
the
the same, like lower lid laxity. Okay, shelving. Second thing is shelving or contracture of the fornix. So the socket is going for a contracture so that it is no more able to accommodate the processes. Okay, so everything we will get from the history itself. The diagnosis also we can make from the history itself. Okay, continue. Next slide. So if the patient is giving a history of implant placement, what other things you should ask?
the patient gives history of implant placement, we should ask regarding the like if like the when it was done, the type of implant if the patient knows, and regarding if if any other problems regarding the implant, like the patient feels that the movements are not adequate.
Implant movement, patient will not be able to see and all. Okay, so what was the indication for the surgery? Why? And what type of implant was placed? If he knows the size, that is well. So all these things should be asked. So what is the significance of chemical injury?
So chemical injury can also lead on to it can also lead to an ophthalmic socket, and
Yeah, that can lead to ocular injury and an ophthalmic socket. But why specifically chemical injury?
chemical injury can cause other components like symblepharon, and they can be it can affect the fornices also, and we should inquire regarding if there is any symblepharon anything, we need to manage.
Okay, so basically chemical injury causes symblepharon. It affects the conjunctival lining and will cause contracture, socket contracture. Okay, and radiation exposure, why?
The radiation exposure will also cause can lead on to the contraction of the epithelial scarring, and which in turn can lead to fornix shortening, and this can also lead on to contracted socket.
Can also cause contracted socket, especially bony contracture also, and that also radiation exposure will cause decreased vascularity. Okay, so that is all high risk contracted sockets, where even repeated surgeries will keep on failing because of the vascularity. Similarly, chemical injury will also cause decreased vascularity of the socket. Okay, next slide. Okay, which malignancy you are thinking in terms of when you are asking this family history?
Family history, mainly any childhood, like for the parent retinoblastoma, like for the parent, you should suspect any childhood malignancy. So if there is any family history of retinoblastoma.
Okay, continue. Next slide.
Moving on to systemic examination. The patient is conscious, cooperative, moderately built and nourished, pulse 78 beats per minute, blood pressure 120/84 millimeters of mercury, taken in the right upper arm. Systemic examination, all the systems are within normal limits. Moving on to ophthalmic examination. Vision, right eye, there's no perception of light. Left eye, the patient reads 6/6. Since the patient's processes has broken, I'll be examining without the processes. External examination, facial asymmetry is present. On the right side, there is minimal temporal fossa flattening, low set eyebrows, deep superior sulcus, near complete ptosis, and there is a small palpable fissure.
Aparna,
Yes, ma'am.
what could be the cause of this facial asymmetry? What could be the cause of this temporal fossa flattening?
It indicates that there is a bony socket contracture. All these features like low set eyebrows, deep superior sulcus, and ptosis along with a small palpable fissure indicates that there's a retarded growth of the bony orbit and the soft tissue, indicating bony socket contracture.
Yeah, bony socket contracture could be there, that we don't know exactly, but moreover, soft tissue contracture is there. And that will happen when the insult happened at the early ages of development. Okay. Yeah.
Ophthalmic examination. Right eye, the lower lid margin has turned outwards and the palpebral conjunctiva was visible, suggestive of grade 2 ectropion. There is no lid laxity present. Upper lid ptosis is present. There is horizontal length of the palpebral aperture is 24 millimeters. Left eye, upper lid ptosis is present. Horizontal length of the palpebral aperture is 28 millimeters.
What is the grading of ectropion? Anju is there? Anju?
Yes, ma'am.
Can you tell me what is the grading ectropion? Anyone else? Ann?
Ma'am, grade 1 is normal appearance, but there will be eyelid laxity on examination. Grade 2 is there will be a scleral show, but there won't be any obvious eversion of the lower eyelid. In grade 3, there is a lid eversion, but there is no eversion of a lacrimal punctum. Then
any other grading, you know? Aparna?
Ma'am, grade 1, there is only the punctum is everted. Grade
Okay.
2, the lid margin is everted and the palpebral conjunctiva is visible. Grade 3, it is everted fully and we can see the fornix also.
Grade 1 is punctal eversion. Grade 2 is eversion of the posterior lid margin, right?
Posterior lid margin and the palpebral conjunctiva will be visible.
That is in grade 3, right?
Grade 3 fornix is also visible.
So what is grade 4? I think grade 4 is fornix is exposed. 3 is when the palpebral conjunctiva is also visible.
Yeah, grade 4 is called tarsal ectropion. The whole fornix you can see outside.
So I think this possibly will be grade 3 or 4. I don't know. We have to see whether fornix is visible or not. How will you examine for the lid laxity?
For examining for the lid laxity, we can do the first we should examine the horizontal lid laxity. We can do the pinch back test where we pinch the central part of the lower lid and see if it snaps back. It comes back. If it is less than 6 millimeter.
Okay, no need to go to the details. Just tell.
Horizontal lid laxity, medial candent tendon laxity, and lateral candent tendon laxity.
Okay, fine. Continue.
Then moving on to the examination of the socket inspection. The surface is lined with wet pink conjunctiva with ill-defined whitish globular structure with vascularization in the center, possibly thysis bulbi. No other anterior segment structures could be discerned. The fornix looks adequate in size, but shelving of the inferior fornix is noted. There's no congestion, discharge, granuloma, or any cyst or papillae. Movement of the thysical globe was restricted.
So what is thysis bulbi?
Thysis bulbi is the end stage of any form of inflammation where the eye will be, where the globe will be discerned, atrophic, along with disorganized, and it will be shrunken and collapsed, and it will be non-functional.
So what is the difference between thysis bulbi and atrophic bulbi?
In atrophic bulbi, it will not be it will not be collapsed. It can be without shrinkage. If there is shrinkage and disorganization, along with the shrinkage will tell it as a thysis bulbi.
In atrophic bulbi, there will be extreme hypertony because of atrophy of the ciliary processes, but the anatomy will be maintained. But when it comes to thysis bulbi, the anatomy is lost, globe is disorganized, and there can be metaplasia of the ocular structures and calcification also later. Okay, continue.
Palpation. The socket is on palpation. The socket is firm, soft to firm in consistency. There is no palpable ocular implant. Insinuation of the fingers below the lower eyelid will lead to correction of the superior sulcus deformity. Rhoplus is negative. There's no tenderness or any other palpable masses. Measurements of the fornix. The superior fornix is 14 millimeters, inferior fornix 10 millimeters, lateral fornix is 3 millimeters, and medial fornix is 5 millimeters.
So why did you insinuate the fingers below the lower eyelid and check for the correction of the sulcus deformity?
It is to see if the superior sulcus deformity can be corrected. Is it because of the because of the migration of the fat from the superiorly to the inferiorly because of the contracted socket, and if it can get corrected, it indicates that it is a volume deficiency, which is first seen in the superior sulcus.
Okay, so when you are when you're insinuating, you're pushing the fat or the orbital soft tissues back into the orbit. So if it is getting corrected with that, that means there is a volume deficiency. One second thing, there can be a stenonucleation socket syndrome. That means there is an inferior and anterior migration of the orbital soft tissues, which is causing a deep superior sulcus and also which is causing shelving of the inferior fornix. Correct. So what is meant by post-enucleation socket syndrome?
The volume there, because of the volume deficiency after enucleation, there will be volume deficiency, and it will first result in the superior sulcus deepening, and after that, because of the superior sulcus deepening, there will be migration of the fat from the above inferiorly.
Not because of superior sulcus deepening, there is migration of the orbital soft tissues and fat. Because of that, it is causing superior sulcus deformity. Correct. Okay, what are the other components?
There will be a deep superior sulcus, the globe, there will be ptosis, there will be laxity of the lower lid, and enophthalmus.
And it can cause ectropion and shelving of the fornix, inferior fornix.
Okay.
Okay. So how did you measure the fornix length here?
By using the Schirmer strip, we have inserted taking the measurements from the Schirmer strip and inserting it into all the 4 fornices.
So from where to where was the measurement taken?
Inferiorly up to the fornix margin.
Yeah, from the fornix up to
the lid margin.
Okay. Okay, ma'am, you want to ask something here?
No, same. This is the thing which I wanted to ask. So what's the normal measurement of the fornices? You are written superior 14, inferior 10. Tell me what are the normal measurements?
The superior fornix 15 millimeters, inferiorly 10 millimeters, medially and laterally 5 millimeters.
Yeah, out of which is little smaller?
The lateral fornix.
Okay.
Then evaluation of enophthalmus by Hertel's exophthalmometer. The measurements are right eye is 15 millimeters, left eye is 20 millimeters, and base of 117.
So in the right side, what you take, which structure you took as the anteriormost limit?
the right eye took whatever was the most prominent part of the thysical eye, keeping the edge on the lateral orbital rim. Whatever was the most prominent part was taken for measurement of the thysical eye.
Okay, so this it may not be very accurate, but it will give you some idea about the loss of volume or the amount of enophthalmos. Okay.
Then evaluation of the ptosis. The right eye palpable fissure height was vertically 3 millimeters. Levator function was 9 millimeter, indicating severe ptosis or pseudotosis. Left eye, the palpable fissure height was vertically 7 millimeters. Levator function 10 millimeter, indicating mild ptosis.
So what could be the reasons of ptosis in this case?
It can be because of the contracted socket. The socket is contracted, and because of the contracture, because of the post-enucleation socket syndrome, because of the lack of orbital volume, it has gone in for ptosis.
So one thing specifically, one thing is volume loss. Then any other cause?
It
Not
can
in this case, but generally any other cause?
It can be like because of the phthisis, it's looking like a thysical eye. It is.
So one thing that is you're repeatedly telling the same thing. One is volume loss. What could be the other causes?
Could be a pseudotosis because of the enophthalmos and.
But now you're telling the same thing again. So one thing is volume loss that will cause pseudotosis. So what other causes could be there for pseudotosis in an ophthalmic socket? Anne, Vrinda, Anju, Christy.
Because of the laxity of the, because if it is not poorly, if it is a poorly fitting processes and even manipulation of the eyelid and
no. So one is volume loss. Second thing is there could be some cicatricial contracture in the superior fornix.
Okay.
So that can cause ptosis. Then, or it could be true ptosis also. It could be, if it is an old person, it could be an aponeurotic ptosis, or it could be something related to the etiology. If it is a case of trauma, so traumatic injury to the LPS could be there, or it could be traumatic third nerve palsy also related to the etiology.
Okay.
Okay, continue. So in this case, we don't know whether it is a true ptosis or pseudotosis. That we should see after the volume correction. After the volume correction and after a properly fitting processes, we should recheck and see. But we will sometimes get the idea from levator function also. Here the levator function is only 9 millimeter. So that means it's what is the grading of LPS function?
More than 10, it is good. From 8 to 10, it is fair. Less than 5, it is poor.
Okay, so there is levator function is also affected here. So there can be a component of true ptosis also. And also another clue is that his normal eye is also having a mild ptosis, and the LPS function there is also only 10 millimeter. So you can also ask the photos from childhood to see whether he had this ptosis since from then also. Okay, so then it could be a congenital ptosis also. Yeah, next one.
Left eye anterior segment, there is mild ptosis of the upper eyelid. Rhoplast negative. Conjunctiva cornea, conjunctiva normal, cornea clear. Anterior chamber normal depth and content. It is quiet. Iris normal color and pattern. Pupil is reactive. Reactive to diameter.
Move to the next slide.
Left eye posterior segment examination. Fundus examination within normal limits.
Then we can okay, diagnosis. So what is the diagnosis?
Diagnosis is right grade 1 contracted socket with phthisis bulbi, right lower lid ectropion grade 2, right enophthalmos, and left mild ptosis.
Okay, right eye ptosis is also there, but we don't know the severity. So it is grade 2 or 3. In other picture, the fornix was seen. So And there is a total tarsal ectropion. Show the picture, go back. Not this one, the socket picture, yeah. So the tarsus is totally everted, right? And you can see the fornix also. This is not where you pull the lower lid, right? It's
No, ma'am. Lower lid is not put up. Upper lid is-
okay. Okay. So must be grade 4 then, or grade 3 or 4. We can classify it like that. And okay, go back to the diagnosis slide. Diagnosis. And what is the grading of contracted socket?
There is a grade 1 where there is a shelving of the lower fornix. Grade 2, there is a shallowing of the superior and inferior fornix. Grade 3, there is a shelving of all the 4 fornices, superior, inferior, medial, and lateral. And grade 4, along with the shortening of all the fornices, there is both horizontal and vertical decrease in the dimensions of the eye. And 5th is a
Of the what? Decrease in the and
palpable apertures, both horizontal and vertical. Whereas
Okay.
grade 5 is there is a recurrence of the socket contraction, like a malignant socket.
so this is which classification you're telling?
Gopal Krishna classification.
Okay. So why you're telling it is grade 1?
Ma'am, there is a shallowing of the inferior fornix. That is, the shelving of the lower fornix is present.
Okay. So other fornices are almost adequate, but one thing is that the palpebral fissure, horizontal palpebral fissure height length was somewhat shortened.
Yes, ma'am.
What is the normal horizontal palpebral fissure?
28 to 30 millimeters.
What was on the right side?
Right eye was 24.
24 only, right? Okay, but we cannot put it as a grade 4 because other fornices are adequate, surface is kind of okay. Then any other, what is the morphological classification?
Morphological classification into anophthalmic, microphthalmic, ophthalmic.
And
And hypoplastic.
so what is each one? Can you explain?
Anophthalmic means it is seen usually after enucleation evisceration surgeries, this is the most common type. Microphthalmic is seen in dicycle eye. After where the eye is small.
So that is in microphthalmic eye.
Microphthalmic eye.
Okay.
Then ophthalmic is seen following any thermal injury, some chemical injury, radiation injury.
Ophthalmic is where there can be thicycle eye or atrophic bulb, whatever. Okay.
And
then what is hypoplastic?
It is congenital developmental problem because of any congenital underdevelopment of the socket.
Because of that, there will be what?
There can be bony contracture leading to
That is hypoplastic. Okay. Then, so what is a contracted socket? What exactly is contracted socket?
contracted socket.
Brinda, can you tell me what is contracted socket?
A socket which is unable to retain the prosthesis.
Very good, very short answer. So, why it is not able to retain the prosthesis?
It can be due to several reasons, like it can be due to the initial trauma.
No. See, what you told your definition is very short. You have to expand the definition. Yeah.
If it can be due to whether it can be because of if the implant is undersized or if the implant has migrated.
And
Ma'am, it is defined as decrease in depth of fornices and orbital volume, which results in the inability to retain prosthesis.
Yeah. So whenever some definition is asked, you have to tell fully. Okay. So there is a contracture of one or all the fornices leading to an inability to fit the prosthesis. Okay. So Aparna, how will you manage this case?
Management. Looking at the diagnosis, every patient will have an individual approach. First, moving on to the investigations. First, we should do a ultrasound B scan needs to be done to rule out any other occult malignancy because it is a blind eye. Then we should take the axial length measurement of the other eye for calculating. It is mainly for calculation. For if we need to put an implant, we need to calculate the axial length measurements.
Not only because it is a blind eye, but we don't know the exact etiology. That is why. If we know the etiology, it is trauma or it is some kind of infection, then UCB scan of that eye could have been avoided. But since we don't know the etiology in this case, we have to do a UCB scan, and also other eye axial length that can be done with an A scan also. So how will you calculate the axial implant size based on the other eye axial length?
From the axial length, we should subtract 2 millimeters, so as to we'll get the ideal size of the implant. For enucleation, we should subtract 2, and for evisceration 1 millimeter.
So okay, some textbook says 2 and 3 also.
Okay, ma'am.
Then so what all sizes are there usually?
Usually 18 millimeters, 22 millimeters sizes
Okay.
are available.
16 to 22 are there available. 16 to 18 we usually put in pediatric children very early, and then in adults around 20 or 22. Okay. Then once the UCB scan is done, you know the axial length of the other eye. So how you are going to manage this case?
For this patient, since the patient does not have adequate, since the patient has ectropion, for the ectropion we can do fornix forming sutures, and we can also, because
not for the ectropion access, but for the
lower because of the fornix shortening.
fornix. Yeah. And if there is a lower lid laxity also, then what addition procedures you will do?
We can do a lateral tarsal strip procedure
if there is a lateral canthal tendon laxity or horizontal lid laxity is there, then that needs to be tightened. Plus an inferior fornix forming sutures can be done to create the fornix. But there is a volume deficiencies also there. What was the Hertel's difference?
Hertel's difference was 5 millimeters, ma'am.
Okay, and even if we put what is the average volume of prosthesis?
Prosthesis will be 30%, whereas a implant will form 70%.
Yeah, that is a percentage. I'm asking what is the average volume of a prosthesis?
2 cc.
Yeah, 2 to 2.5 ml. That is the volume. So here the difference is 5 millimeter, and that will not be compensated with a prosthesis alone. So
we should put a graft so that we can get adequate orbital volume.
Graft. What are the options of volume replacement?
Volume replacement, mainly we can do a dermal fat graft, or we can place along with that we should place an implant.
Along with the dermis fat graft.
No, ma'am, we can do a dermal fat graft.
Okay, that is one option. Other options?
Implants. Then following enucleation, we can place an implant, or we can do enucleation or evisceration, and then we can put an implant after 6 weeks.
After 6 weeks, what?
The prosthesis we can put for the cosmetic purpose.
Okay, so you can do, if you will see, do a USGB scan and see how is the sclera, if it is healthy, and if possible an evisceration. If not possible, if then an enucleation plus ball implant. And other option is dermis fat graft. What is the advantage of dermis fat graft?
The advantage is that because the epidermis is removed and it will take around 20 millimeters. Since it is it is like a membrane, there'll be less chance of migration, and the edge of the conjunctiva will be similar. There'll be shrinkage of fat is very less.
No, you're mixing up everything. Advantage of what is the advantage of a dermis fat graft over a implant, ball implant? Brinda, can you tell me?
Migration is less.
Yeah, that she already told. Any other? And
Dermis fat graft, it contributes to both the volume and area of the socket.
so you know what, then why are you not telling the answer? Whoever knows the answer can tell. Okay, we have to finish this. So it is a composite graft. That means it has it will provide both surface and the volume. It has the dermis that will give the surface area. So we can, as she told, we can suture the conjunctiva and the extraocular muscles to the edges, and the conjunctiva will gradually grow over the dermis and cover it. So an advantage is the surface area. So if there is a soft area, surface contracture also, then this is a very good thing. But otherwise also dermis fat grafting can be done as a primary implant, primary volume replacement, because there are many advantages. Like you told, migration, implant can be migrated, implant can get infected, extrusion, exposure. So all those complications are less. Okay. Then, so from where will you harvest it?
We can harvest it from the gluteal region,
Okay.
then from the thighs.
Okay. Can you tell the anatomical landmark?
For the gluteal region, from the we'll take we'll remove the epidermis and we'll take around 20 millimeters of the skin, leaving the bare dermis. Along with the dermis, we'll take the subcutaneous fat is also taken.
Why you have to remove the epidermis?
Hair growth.
Yeah. So one is that we don't need the keratinized surface, right? So we have to remove the epidermis so that the conjunctiva can grow over the dermis. Second thing, if you keep any part of that epidermal elements, sweat glands or cilia, so that will cause what, a hairy and a smelly socket. So nobody wants that. So we have to completely remove all those cutaneous appendages. Okay. I asked the anatomical landmark. So you have to take from the upper lateral portion of the thigh, of the buttock region, where not on the pressure bearing area, line joining from the anterior superior iliac spine and the ischial tuberosity. So what size you usually take?
20 millimeters.
You have to measure how much volume and surface you need to replenish first. And do we have to take the same size, or should we add some extra?
We can add a little bit extra because there can be shrinkage.
Yeah, there can be shrinkage also. Okay. Vrinda, can you tell me what types of implants are there?
Ma'am, implants can be non-integrated, semi-integrated, bio-integrated, and biogenic implants.
Okay.
What
is first classification? Primarily, there can be porous or non-porous.
Non-porous.
Can you tell me some examples for porous?
Hydroxyapatite.
Okay.
So for non-porous, it can be PMMA.
Any other example?
Silicon and PMMA.
Okay. Porous, one is hydroxyapatite, then?
Aluminum oxide, Medpor.
What is Medpor? Medpor is
polyethylene, porous polyethylene.
Yeah. So then what is integrated implant?
In integrated implant, there will be integration of the structure to the surrounding soft tissue, and along with it to the processes.
That is bio-integrated.
In integrated, there will be integration of the implant, indirect integration of the implant to the surrounding soft tissue as well as to the processes.
No, see, there is integrated, non-integrated, and quasi-integrated, and then there is bio-integrated. Integrated means the prosthesis and the implant, it is connected with a peg. Okay, so that the movement will be directly transferred into the prosthesis. Non-integrated means there is no connection, The implant will be lined with the surface and prosthesis will be there on top of that. There is no connection. Then in quasi-integrated means the posterior surface of the prosthesis and the anterior surface of the implant will be fitting to each other. There will be molds and valleys, so they will each fit to each other so that there will be some kind of movement transfer. Okay. In bio-integrated means the others vasculature and connective tissues, everything will grow into the implant. So that happens with the hydroxyapatite porous implants. Okay, don't get mixed up all these things. Okay, then Mariam ma'am.
Yeah, continue the discussion. I will just add on in the end.
Okay. Yeah. Okay. So, what are the complications that can happen in an anophthalmic socket?
Can go in for a contracture.
Then, so we already told almost every point. Can you summarize what are complications that can happen in an anophthalmic socket?
Can go in for contracture. Then the contracture, there can be post-enucleation socket syndrome.
Okay.
There can be shelving of the inferior fornix, lower lid laxity, ectropion, fornicial shortening, decreased orbital volume.
Fornicial shortening and a decrease in orbital volume is everything goes for contracture. That means the contracture itself. Okay. Yeah. Then. So you can, okay, I will give the clue. You can tell, you can classify them. It could be lid related, it could be surface related problems, it could be the implant related problems. So, yeah. So now can you tell me what all lid related complications can occur?
Lid related, there can be lid laxity, there can be ectropion or entropion, there can be ptosis and or pseudotosis. Then
what can cause entropion? Ectropion, we know the laxity can cause ectropion. Okay, then entropion, what could be the reason?
The lamellar shortening, anterior lamellar shortening.
Anterior lamellar shortening or posterior lamellar
shortening?
Okay, or thickness can cause entropion or inverted lashes. Okay. So these are the lid related complications. Now, what are the surface complications that can occur?
Surface related, there can be infections like papillary conjunctivitis. There can be inflammation. There can be granulomas. There can be conjunctivitis or any other infection also, like dacrocystitis.
Okay, one question we already asked. I think we missed few points. What can cause discharge from the socket? We told conjunctivitis, pyogenic granuloma. Anything else?
Because of any sac inflammation also can.
Yeah, even nasolacrimal duct obstruction, dacrocystitis can cause discharge. Anything else? Something related to the nasolacrimal duct itself? Or the lacrimal drainage system?
Punctal occlusion.
Canaliculitis. Okay, so that is also important. You have to see the periocular area also, the lacrimal apparatus. Okay, okay. So surface related complication, discharge, papillary conjunctivitis, granulomas, conjunctival cyst. What could be the reason for conjunctival cyst?
Because of the retention of if there is no proper, the fluid can get collected. And
it is usually like the conjunctival elements, epithelial elements, it get in between the sutures. So it goes deep and then the collections get collected, can cause cyst. Okay, so surface, there can be bands, band formation can be there. Then what are the implant related complications?
Implant related, there can be implant malpositioning of the implant, extrusion of the implant. Then the ill-fitting implant, the implant can migrate and
before getting extrusion, what can happen first?
It can go in for migration from the normal position. Yes, ma'am.
exposure.
Okay.
So first it will get exposed, then it will get extruded, and it can get migrated also. So how will you manage a case of implant exposure? And
Wrapping of implant.
directly will go and wrap the implant. Say okay, there is an implant exposure, say 1 to 2 millimeter sized. How will you manage?
Lubricants.
Yeah, first you can do a conservative treatment. You can topical antibiotics, see if there is any infection, and see how whether it is getting closed by itself. If it is not, then you can think of other methods. So if it is not getting closed or little bigger sized exposure, then you can undermine the surrounding conjunctiva tenons and try to close it. Or if it is not closing by that, then you can, provided there is no infection, then you can look for other options like sclera, or you can use fascia, lata temporalis fascia or something like that. Okay. So if the then say if the exposure is more than 50%, then what will you do?
Wrapping the implant.
If there is very much exposure, or that means the implant is almost extruding, then we cannot do anything. Then we may have to replace the implant, remove the implant, and then once the infection and everything is controlled, surface is okay, then at a later stage we can go for a secondary implant or a Ternis fat graft. Okay. So what are the causes of contracted socket, etiology wise, Aparna?
It can be because of the lack of orbital volume.
No, etiology. What are the causes for contracted? What all factors can lead to a contracted socket?
It can be because of the lack of lower lid laxity.
Brinda?
Alkali burns.
Mhm.
Then any radiation therapy. Then
Okay.
any cicatrizing conjunctival diseases.
Like?
Then like Steven Johnson.
Okay. And more common? Ocular cicatricial pemphigoid. That is a common one we see usually, right?
Yes, ma'am. Yes, ma'am.
Then?
Like in not properly done, like enucleation or evisceration.
Yeah, not properly done means what?
Over dissection, I mean extensive dissection of the orbital tissue.
Yeah, during the primary surgery.
Surgery.
Or?
Multiple socket surgeries.
Okay.
Then extensive dissection leading to formation of increased scar tissue.
That you already told, extensive dissection. Anything related to conjunctiva or tenons?
Extensive dissection of conjunctiva and tenons.
And not preserving conjunctiva and tenons as much possible. Okay, or undue removal of the conjunctiva or tenons. And how can you prevent? What all measures you can take during the surgery to prevent, or after the surgery to prevent a contracted socket?
We should tell the patient not to frequently remove the socket.
Yeah, that is after the surgery, right? During the surgery, intraoperatively, what all measures you will take?
Avoid excessive dissection of.
Yeah, okay. And a meticulous surgery, a meticulous dissection. Then
avoiding ill-fitting or ill-fitting prosthesis.
Okay, before that, in the surgery itself, you have to preserve the tenons and conjunctiva as much as possible, and a layered closure. So first you will close the tenons, sclera, tenons, then the conjunctiva in layer. And also you should take care not to cause undue tension. You should, just to close the conjunctiva, you shouldn't be pulling all the conjunctiva from the fornixes. Then the fornix will get obliterated and you will not be able to put a prosthesis later and will lead to contracture. So a careful closure is very important. Okay. And the other thing is an adequately sized implant during the surgery itself. So that is why we have to calculate the implant size. And implant will not be oversized. That will cause to exposure and extrusion of the implant, and should not be undersized also. That will cause contracture. And so the implant, the surgery, then immediately after the surgery, what should we do?
Place in the
Conformer
conformer.
should be.
Yeah, confirmed is very, very important. It should be an adequate size conformer. Okay. Then after that,
Elimination of any source of infections from the lip margin.
after 6 weeks, you have to put a ideally custom-made prosthesis, because that is suitable for the socket. Even say stock shell will cause some kind of contracture because of ill fitting. Okay. And if possible, put a custom-made prosthesis itself after 6 weeks, and then you have to provide some lubrication constantly. And as we already discussed, avoid taking out and cleaning the prosthesis frequently. Ideally, it should be done in every 2 weeks, okay, if possible. Then polishing regularly, so that will prevent the irritations, surface irritations. Okay, so what all kinds of ocular processes you know? Aparna?
Ma'am, the stock shell and the custom-made processes.
Anything else?
Scleral shell.
Yeah. So how the scleral shell will appear?
The
It appears
shell
as
will
a
be
transparent.
transparent.
Okay, fine. Yeah, the scleral part will be transparent. So suppose in this case, he had a blind eye in the right side, and the Hertel's value is showing a difference of 2 to 3 millimeter only. So, and there is no lower lid ectropion or laxity. How will you manage this case?
We can do a, if there is for the surface, we can do surface reconstruction.
Wait. How much did I tell you? The difference in Hertel?
3 millimeters.
2 to 3 millimeter. Okay, his surface is fine. There's no lid laxity. Connexes are adequate. He wanted cosmesis. How will you manage?
We can go for a custom-made prosthesis.
Okay, custom-made processes or just a stock shell also will be fine. Okay, so it all depends upon how will you, like, management depends on what the patient wants, and what is there. There is surface contracture or there is a volume deficiency. So depending on that, you have to think. Say this is suppose this was a contracted socket of grade 3 or 4. How will you manage?
Then grade 3 or 4, we should first we should replace the volume. So we can do a dermal fat. We can do a dermal fat graft, and after 6 weeks, we can put a prosthesis.
So what is grade 3 contracture? Can you tell me again?
There is a shortening of the superior, inferior, medial, and lateral fornices.
Okay, so there is only volume contracture. There is surface is adequate.
Surface is also there is decreased surface, anteroposterior and vertical dimensions.
Grade 3 or 4 means there is a serious surface contracture also. So how will you manage?
So we can, if there is, along with that, if there is surface contracture also, we can go in for a mucous membrane graft, which we can take from the lips, the cheeks, or the buccal mucosa.
Yeah, from the hard palate will not be suitable. But from the cheek you can take, yeah, from the lips you can take, and ideally how much you can take from the lips? Average size around 3 into 1.5 you can take from the lips. Okay, and also while taking from the cheeks, what you should take care of? Is there any important structure there?
The nerve.
No.
Parotid gland duct.
It opens against the crown of the second molar tooth. Okay, upper. So that area should be careful dissection in that area. Then, okay, so you have to reconstruct the surface with a mucous membrane. if there is a surface loss. So this socket reconstruction is very, not simple, but the logic is very simple. So you have to see what all problems are there first, whether there is a volume, there is a surface, or if there is any lid problems. So all the lid problems are taken care only after the surface or the volume is provided. If the patient is willing, that is also important. Okay, yeah. Then because the ptosis will change, the ectropion may change. So we have to take care of the surface and volume first, and then the lid problems. So in this case, suppose a patient is not willing for a big surgery. So he just wants his prosthesis to be fitted. So what will you do?
We can do a volume replacement.
No, he's not willing. Okay, volume replacement by?
Some bone. We can use a bone implant.
No, he's not willing for a surgery, major surgeries.
Then we can try any filler injections.
Filler where?
Retrobulbar.
So that will correct. Okay, filler, if he is willing, we can give retrobulbar like into the orbit. So that will give the volume, but still he will not be able to fit the prosthesis. What will you do?
We can give a. I can give.
We already discussed. See, his problem, the lower fornix is not fitting the prosthesis. So to correct that, you can put a suture, fornix forming suture. Yeah, that's it. So what the patient wants, you have to ask. And then accordingly, we can give the options of everything, but we have to take care of their demands also. Okay. Ma'am, you want to add something more?
Yeah, I just wanted to add. Aparna, you said evisceration ball implant. So is it possible in this case?
It is not possible because, ma'am, the patient does not have any the eye is thiacical. There is no proper.
Suppose B scan shows an axial length of 10 millimeter or 8 millimeter. Is it possible?
No, ma'am, because it is not adequate for the.
Okay, fine. I partially agree with you. What is evisceration?
Evisceration is a removal of the all the intraocular contents, leaving the sclera and part of cornea.
What are the different types of evisceration you know
of? Can be total and subtotal evisceration.
This is which classification? I mean, I haven't heard of. Anne Maria, Vrinda, types of eviscerations you know of. Christy. Okay, have you heard of any frill evisceration? Have you heard of? What is frill evisceration? That is not
sclera. We leave a frill of sclera.
That is usually done in.
It is done in cases where there is a limited. When it is not much affected, only a frill of tissue is
Left to be
removed.
Yes. Okay. Usually done where? Anne Maria.
Ma'am, in panophthalmitis.
Yes. So it's done in panophthalmitis. So here the sclera is very, very small. So what is four-petal evisceration? Something you heard of that type? Four-petal. Aparna? Okay, so in four-petal, you make 4 petals with recti in each petal. So the advantage is you can implant large sized implant, like say 20 normal implant. So if the sclera is like only 8 millimeter, the axial length is only 8 millimeter, obviously you cannot put a big implant. Okay, so in that case, what you are doing is you can make 4 petals and you can insert 20 sized implant you can put.
Okay.
Okay. So you have fitted the prosthesis after 4 weeks. For 6 weeks. Okay, then what will you tell the patient? Your management stops with that?
No, ma'am.
Oh,
Regarding the proper hygiene, the patient should wash the hands and it needs to be removed only once in 2 weeks.
okay.
And while handling the processes, he should maintain strict hygiene.
4
Then
things you should tell the patient. 4 things. So one is like removal once in 2 weeks. Then
regarding putting of lubricants.
okay. Yes.
Then regarding frequent checkup, like the patient should have regular follow-up.
I mean, you see, regular follow-up is a non-specific terminology. How regular?
At least 6 months.
Yes, that will be too much. If every year he needs to have a checkup for
Checkup,
Polishing.
polishing. Then
one is polishing of the shell. 2,
to see the socket.
examination of the socket. 3,
Then to see the
no, so you have to check the normal eye, obviously, no? Yeah, you have to see every year to see the dilated fundus because that is the only eye for the patient. Okay, then 4th thing.
The patient should, if the patient has feels any increased discharge or anything, to
that all already we have included. So what is for protective glass?
We should ask the patient to wear a full frame polycarbonate glass so as to protect the other eye from any forms of injury.
Yeah, fine. So I have got one doubt. Patient is asking, can I get full range of ocular motility? So what will you tell the patient in this case?
You can tell the patient that the patient will have a conversational movement. That is there will be 10 to 15 degree of 70% there will be movement.
No, in this case, what is the motility of that thusical eye? Is it full?
No, ma'am, it is restricted.
So do you think after implant will the patient get the full motility?
No, ma'am.
Yeah.
So it will be 70%.
Little less than the existing movement or the same as the present condition.
Okay.
Okay. Then enucleation is an option in this case. So our first option is dermis paragraft volume replacement.
Second,
the patient doesn't want another graft from his body. So you can have a 4-petal evisceration with the ball implant. If that is also not very practical or not very confident with that, what's the other option?
And do enucleation and ball implant.
Yes. Yeah, do enucleation and either dermis paragraft or ball implant can be done. Then any doubts from anybody? Final question, like, can he drive?
And
No.
drive this for category one we can drive is the vehicle. The left eye, based on the left eye, the vision. He can go in for category 1 if his vision is good in the other eye.
Now you have examined the patient.
He can go, ma'am. He can.
That's what I'm asking. See,
he can drive.
So what? You are the treating doctor, and he came for you for driving license. Then how will you proceed? You said you will give category 1 driving. Anything else would you like to do?
We'll do a full field. We should do a visual field assessment. We should do a full 120-degree visual field, so that to see if these visual fields are the left eye, if it is adequate. 120.
Okay. Yeah. Okay, you have to do a full field 120 visual field analysis, or that is Humphreys, or you have to do Goldman, whatever. Okay. Suppose he came to you after 3 months. Then 3 months he came to you for prosthesis or socket rehabilitation, and you did dermis paragraft and you gave a nice prosthesis also. Then he is asking you driving license. Will you give?
We can do a can give him a visual field, we should assess, and we can
Only 3 months, no? Anne Maria?
after 6 months, after 6 months.
Ah, yeah. So that is very, very important. So one night, wait for 6 months to give a driving license. Anything else? So another last question. Like we have already discussed phantom pain and all. No, what is phantom eye syndrome?
The patient will have
Anybody can answer. What is phantom eye syndrome?
Ma'am, any sensation reported by the patient in case of anophthalmia?
Yeah.
It can be
One is phantom sensation, phantom pain. Any other things?
random vision also.
Yeah, phantom hallucinations primarily. So phantom pain, phantom sensations, and hallucinations. So that is called phantom eye syndrome, which is nowadays very much reported in an ophthalmic socket. So we should know when you treat this kind of cases. Sometimes they will come and tell you, like, I'm seeing this, I'm seeing that. So you have to reassure them. And to some extent, prosthesis or socket reconstruction help to alleviate this phantom eye syndrome. So in that way also, apart from cosmesis alone, functional aspects are also for this socket rehabilitation. Okay, Dr. Shebin, I think we have almost.
Just want to add one thing. Suppose the patient came with the prosthesis, what all we should tell in the examination part?
the patient has come with the prosthesis, which we should examine the cosmesis of the prosthesis, the paint and color. Then we should examine the we should check if there is any lag of thalamus. Then the closure. Then we should assess the ocular movements, that is conversational eye movements. Then we should assess the symmetry with the other eye. We should check. And on palpation, we should check the surfaces. We should examine the surfaces, anterior surface, posterior surface. We should check for any debris or any other material on the prosthesis.
Surface deposit, cracks of the edges. Okay, yeah. That's it, ma'am. I think we can conclude.
Yes.
Thank you very much, Dr. Marian and Dr. Shebin and Dr. Aparna for braving the case. It was a wonderful discussion, right from the initial evaluation to, to even for driving license.
No,
Very
that we should know actually.
Yeah, very practical class. Thank you very much, Dr. Marian and Dr. Shebin. It is really a wonderful thing. And I hope that this would definitely be of a significant use to the postgraduates, because contracted socket is not something that, every day we have a discussion on. Thank you very much for making this so much lively, both of you. And Aparna, thank you very much for presenting this nicely.
Thank you, Aparna.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you. Bye. Thank you.